at the end of this business, so we are recording. Before we get to joints, which is chapter 8 in your textbook, I do want to say some things about, so I'm calling up a whiteboard right now. I do want to say some things about bone deposit and bone resorption. You already know most of this. These are just words that I'm going to use possibly during the quiz. Both of these together make up the process of remodeling. Bone deposit just means ossification or laying down new bone matrix. So this is predominantly the job of osteoblasts and mineral deposits. Bone resorption is breaking down or dissolving bone matrix, which is the job of osteoclasts. So in bone deposit, we know that osteoblasts secrete an uncalcified stuff called osteoid. So this is an uncalcified organic portion of bone matrix. It gets secreted and then it gets calcified. And that's from minerals brought into this area by blood vessels. So a blood vessel brings minerals, particularly calcium, to the area where we have osteoid, and it all mixes together to make, crystallizes, and makes a really hard matrix. So we need a local supply of calcium and phosphate in the endosteal cavity of the bone, meaning somewhere inside of the bone itself. So that's bone deposit. Now, bone resorption is carried out predominantly by osteoclast activity, which are derived from macrophages, not from osteogenic cells. These cells are big, large cells. They migrate along bone surfaces and they sort of create grooves and depressions along that surface. They're big, they're multinucleate cells, and they have ruffled edges to them. And they sort of migrate around, dissolving bone matrix. They grab the bone surface kind of, and they secrete, the cytoplasm secrete hydrogen ions, which is very acidic, and also lysosomal enzymes. That's supposed to be a Y. These two things, hydrogen protons and lysosomal enzymes, dissolve or break down bone matrix. So that dissolves this stuff that was made by osteoblasts and minerals. So calcium salts then convert to soluble form. So the calcium that's inside of the hard bone matrix, once it gets dissolved by these osteoclast secretions, the calcium salts convert to a soluble form, and with growth factor and other dissolved minerals, they get endocytosed out of the matrix, out of the cells, then transported through osteoclast cytoplasm. So this stuff, I'm just going to draw a calcium mineral. It actually migrates through this osteoclast and released then back into the blood. So it's a cycle of creating new bone, that's bone deposit, and dissolving bone and releasing calcium ions back into the blood where they originally came from. That's how we regulate blood levels of calcium here, as well as making new bone and breaking down bone out here. So I did want to go through that process one more time with you. Now we can call up a new board I'm going to say just a few things about chapter 7. It says on your outline, as well as in the sections that are listed that you need to know for the next quiz, that the quiz is going to cover almost all of chapter 6, some of chapter 7, and I believe 8.1 through 8.4. So I get it. You're probably thinking, what do I have to know from chapter 7? Most of chapter 7, when I teach this class in person, I actually don't need a whiteboard right now. Most of chapter 7 is done in laboratory. So when this course is taught in person, we do all this lecture business, blah, blah, blah. You learn about how bone tissue works and the physiology of it. And then you actually learn all the bones and markings in a laboratory setting. Because we can't do that, most of the bone lab business is done in those lab exercises that have been assigned to you to complete with the Wiley Plus lab assignment, because that's the best we can do. On lecture, in the next quiz, I'm going to ask you a few questions about general bones themselves and possibly some bone markings. That's actually table 6.1 in your lecture book. So that is in chapter 6. But from chapter 7, what I mean by general characteristics is, if I ask you the name of this next lecture quiz that's in the skull, I'll expect you to be able to know that it's a cranium bone or a skull bone. For example, the humerus is in the upper arm. You should know by now from doing the lab exercises that the humerus is not in the head, that the femur is the upper leg bone, that the tibia and fibula are the lower leg bones, the tarsals are the ankle bones, the carpals are the wrist bones, phalanges are the fingers, the sternum is the breastbone in front, the scapula is the shoulder blade, clavicle or the collarbone. So that's what I mean by general characteristics. So you should, but at the very least, be able to recognize from memory right off the bat what the basic bones are of the human body. Perhaps not all 206 bones by name, but most of the general bones of the axial and appendicular skeleton, okay? So that's what I mean by chapter 7, general characteristics. That's not going to be the majority of the quiz. The majority of the questions that I ask from this quiz are going to be from chapter 6 and from chapter 8. And then I'm going to just pepper in a handful of questions from chapter 7, just because I feel guilty as the instructor not asking you any questions on a test about actual bones from the human body. So let's get on to chapter 8 now. And we're going to talk about joints. If you have any questions for me just at the end, just feel free to chime in and ask me any questions you'd like. Joints are what we refer to as both articulations and this word, arthroses. So whenever you hear or read articulation, just think where a bone meets a bone, and it has usually a functional capability as well. Same with this word, arthroses. If you see this within a term or a word, it means joint. So for example, the word arthroplasty means an imitation or synthetic joint. You'll get used to this. Now we're going to classify joints based on function. This is first and foremost, this is the easy one, by the way. Classification of joints based on function. That's the important word. All joints structurally classified after this will fall into one of these three categories. First one are called SYN, S-Y-N, arthroses. So you can see the word arthroses in there, that just means joint. Or if That's a noun, synarthroses. If you hear me say synarthrotic, that's an adjective describing this type of joint, okay? These are basically immovable joints. So they are articulations from bone to bone where there is no movement. That would be synarthroses, or a synarthrotic joint. The second classification based on function is amphi, A-M-P-H-I, amphiarthroses. That's also a noun. If you hear me say amphiarthrotic, that's just an adjective. These are slightly movable joints. And finally, the third category, diarthroses or diarthrotic joints are fully movable. So all joints that we're going to cover next based on structural classification are going to fall into one of these three categories: immovable, slightly movable, or fully movable. So just so you know, based on this functional classification, the axial skeleton, by and large, falls into these two categories. And the appendicular skeleton, this is a generalization, is generally number 3. There are some exceptions to that, though. Also, just to remind you, I know you know this, we've already been over this, there are 3 types of cartilage in the human body. Those are, just to remind you, those are hyaline, that's a Y, elastic cartilage, and fibrocartilage. We're going to talk about, when we talk about the structural classification of joints, when we get to a certain group of them, we're going to use these terms. So that's just to remind you that these are found in joints as well. All right, now we're going to go on to a little bit more of the nitty-gritty. Just remember, here's my disclaimer, I can't talk about every single word in the chapters of these books. I just don't have time. You need to read this in its entirety. I'm highlighting the major points of these sections in the book. So now we're doing structural classification of joints. This is more complicated than functional classification. So I'm going to use large number 1, large number 2, and large number 3. There's 3 main structural classifications, but then there's subgroups within those. Number 1, these are fibrous joints. That means all joints in this structural classification group are made up of fibrous connective tissue. And so I'm just going to put made of mostly collagen fibers of connective tissue. There's typically no joint cavity. It's filled with, the space is filled with, if there is much space, totally filled with fibrous connective tissue, dominant in collagen fibers. The length of the connective tissue dictates the degree of movement. Most of these are immovable, but the shorter the connective tissue, the more immovable it becomes. So now we're going to do this, there's 3 subcategories of fibrous joints. I'm going to use letters instead of numbers here. First subgroup are sutures. I know you know this word, not from a surgical suture, but from a bone suture. These are formed between, they're also called seams, and they're formed between, they're only found bones of the skull. So they're unique to that area. And there is typically, when we are young, we have sutures between our cranial plates mostly, but we find these in the skull. They do allow for expansion when we are young. So they're not fully fused, these sutures, when we are young. Young meaning right after we're born, like the, the baby's newborn soft spot on top of their head. That's a wide open seam that's allowing for expansion of the head and mostly the brain. But also sutures all over our skull remain somewhat open, allowing for expansion until we are fully grown. And that means, like, especially for males, females close a little bit earlier, but for males, it might be in their late 20s until their sutures fully fuse within their skull. I'm just going to put fully fused by, let's just say, middle age, where they become completely immovable. These are also called synostoses, and that word basically just means immovable. So technically, to just be super technical, after they are fully fused, after middle age, synostoses is a more accurate word than suture. I'm going to do this with all of these structural classifications. So we would call these, in a functional classification, we would call these synarthrotic. That means immovable. All right, let's move on to lowercase b. This is the hard part, is just organizing this stuff, in my opinion. Syndesmoses, also that these words sound alike doesn't help, is the second subcategory in fibrous joints. So syndesmoses are bones connected by ligaments. So throughout even our appendicular skeleton, bone-to-bone connections are ligaments. So are sutures, but sutures are specific to special connections within the skull. These are bone-to-bone connections outside of the skull, mostly. Syndesmoses. The degree of movement here depends on the length of the fibers. So that's important. The longer the fibers, the more movement. The shorter the fibers, the less movement. So examples of these syndesmoses would be, we have in our lower leg, below your knee, you have two bones, the tibia and the fibula. They're actually connected to each other by ligaments. So I'm going to draw a tibia. It's kind of T-shaped, like this. If this is somebody's left leg. And then a fibula is connected to it here and here. Right at these connection points would be a syndesmosis. So let's just write example, tibia fibula connection. So there's like also the interosseous membrane of the radius and ulna. So let's do that. In the lower arm, in the forearm, the radius and ulna are also connected by a syndesmosis ligament type of joint. These, the first example, are very short fibers, so they're barely movable at all. These tend to have longer fibers and so have a larger degree of movement. And before we move on to the next one, just like I did, let me erase this. Just like I did up with the sutures out here, I'm going to write these are amphiarthrotic, slightly movable. Okay. Now I'm going to call up a new whiteboard layer over this one and just go to letter C, which will be the third subcategory of fibrous joints. That's pronounced gomphoses, G-O-M-P-H-O-S-E-S. This is basically, the word just means peg in socket. It's like a nail going into a piece of wood or a hole. The only place we find this in the human body is the teeth, where the teeth actually articulate with the maxilla and mandible. This is very short, very short fibers of connective tissue. So short, in fact, that it provides no movement. And so we can call these special types of joints synarthrotic, because that means no movement. Remember, that's a functional classification. And we're going over structural classifications right now, what type of tissue they're made of. So that takes care of all the fibrous joints, which is good. We've done A, B, and C of the fibrous joints. Now I'm going to go on to large letter 2. And this is going to be joints that are made of cartilage. So I'm just going to write cartilaginous joints. And also, we don't have 3 subcategories in this one, just 2. Makes it slightly easier, so I'm just going to write letter A. Cartilaginous joints, it's just the 2 bones are joined by cartilage, not fibrous connective tissue. That's pretty self-explanatory in the name. So the first subcategory syn means tight or immovable. Chondro, you know what that means? It means cartilage. So these are, just so you know, are bones that are joined specifically by hyaline cartilage. Remember, I wrote out the 3 types of cartilage at the beginning of this: hyaline, elastic, and fibro. All of these synchondroses are hyaline cartilage joints. So that's based on their structural classification. Examples of this, by the way, I'll write this later, but they are considered immovable. Examples of these would be that growth plate that we went over in a previous lecture. So epiphyseal plates, rib number 1 to the manubrium of the sternum. Those are classic synchondroses joints. These are syn, which helps you, syn. These are synarthrotic. That means immovable. So I'll write that over here. So synchondroses, just remember hyaline cartilage and that they are synarthrotic. Classic example would be an epiphyseal plate. Now we do get damage to those growth plates if they're put under a lot of trauma, but in general, they're not supposed to move. I'll try to squeeze in, just so I don't have to confuse you and go to a new whiteboard. The second subcategory are symphyses. These are bones that are specifically joined by fibrocartilage, not hyaline cartilage. Fibrocartilage is sort of stringy. It gets its name because it's full of these very visible fibers. Remember, we find that stuff in intervertebral discs, the knee joint. So fibrocartilage, that's its definition. We do get some limited movements. First, I'll give you some examples. These are our classic ones from our tissue section way back the first week. Enter, there's supposed to be an R there, so I don't want to spell that wrong. Intervertebral discs. Sorry about the writing, it's hard with a plastic pen on a glass surface. The pubic symphysis in the front of the pelvis between the two pubic bones. These are classic symphyses examples. And over here, I'm going to write these are amphiarthrotic because they are slightly movable. You know that you have some movement between the bones in your vertebral column. That's mostly provided by these intervertebral discs. Also, the pubic symphysis, you probably don't know that you have some movement there. For pregnant mothers, during child labor, when they're giving birth, that symphysis actually softens and allows for expansion for delivery of the child. So that takes care of the cartilaginous joints. Now let's go on to big category number 3, and there are no subcategories, which makes it easier. Number 3 of structural classification, these are called synovial joints. This is more common to what you and I think of when we hear the word joint. These are specifically, by definition, bones separated, they don't use the word joint, but separated by a fluid-filled cavity. So that's their definition. Just so you know, these are diarthrotic, and so they are fully movable. And in order to be fully movable, we need this fluid-filled cavity. Some are more movable than others. You can learn about, I'm probably not going to have time to go through every single joint in the human body, obviously, today, but you can read about those in your textbook. I'm more concerned about right now during this lecture, helping you understand how a synovial joint is constructed. So there's basically 6 structural elements to these joints. These are distinguishing features. There is a layer of articular cartilage, and that would be hyaline cartilage, by the way. There is a joint cavity. There's also something called an articular capsule. I'll draw a picture in a moment. This is just connective tissue layers. There is fluid, and we call that synovial fluid from the name of the joint. Now this fluid, I'm going to say a few things about it, contains hyaluronic acid. It's secreted, the fluid is secreted, and the fluid contains a product called hyaluronic acid. It's secreted by cells in the membrane of the joint itself. And what it does is it helps the fluid overall, but hyaluronic acid also helps decrease friction or reduce friction. Just like oil in the engine of your car. So we've got 1, 2, 3, 4. There are also ligaments. that make up part of this joint, and these are structural for reinforcement of the joint. And finally, I'm just going to write nerves and vascularization, blood vessels. Obviously, to provide sensation and nutrition. So some of these synovial joints also have fat pads, or what we call menisci, which are pads for articulation, a meniscus. I need to layer over this. Those are the 6 structural elements. There are also, we find, I'm still continuing with synovial joints, but we also find bursae. You've probably heard of a bursa. Plural is just with an E at the end. If you drop the E, we're just talking about one. These are basically fibrous sacs that are filled with fluid. And we find these bursae near synovial joints, and they also help reduce friction around these joints. So I'm just going to write found. So technically, they're not considered part of the joint itself, but they're closely related location-wise and structurally. There's typically also something called a tendon, that's a D, T-E-N-D-O-N, a tendon sheath in the area of synovial joints, or more than one sheaths. These are sort of long bursae around, specifically around tendons. And it helps reduce friction between tendons and bones. So many of our tendons ride over the top of bones, and these tendon sheaths, which are just elongated bursae, help reduce friction as those tendons ride or glide over those bones. Before I draw a synovial joint, I'm just going to finally list factors that regulate or actually influence synovial joint stability. So these are like extra things that help stabilize synovial joints, because they are the weakest joints. They're the most movable in the human body, but they're also typically the weakest. First, the shape of articular surface. That helps or not, it helps dictate or influence the joint stability. So if we have, for example, let's just say the femur, here's the bottom of the femur, I'm drawing a knee joint here, there's the top of the tibia. The shape of this joint, the articular surface here, right in here, is very different than, say, the humerus, the head of the humerus, in the glenoid cavity of the scapula, like this, or the head of the femur and the acetabulum of the hip joint, like this, of the ilium. So the shape of the articular surface influences the stability of that joint. Also, the number or amount of ligaments within the joint, stabilizing that joint. Obviously, the fewer ligaments, the less stable the joint would be. The more ligaments, the stronger the joint. And finally, the muscle tone of muscles within that joint or contributing to that joint. This is, by the way, I'm going to put a star next to this one. This is the most influential of all three. So the stronger the muscles around any particular diarthrotic joint or synovial joint influences the strength of that joint more than anything else. The better the muscle tone, obviously, the stronger the joint. Now I'm going to draw for you a typical synovial joint, just so that many of these things that we've listed in word form, we can actually picture. And I'll try to use as many colors as I have, which isn't a whole lot. I only have access to about 4 or 5 colors, but I'm going to draw a bone. I'll make it sort of like a knee joint. This is the distal end of the femur, so the top of your knee. Now I'm going to draw the proximal end of the tibia, which is the top of your shin. And I'm going to draw this synovial joint for you. So those are obviously bones. Now there's a hyaline cartilage, which acts as an articular surface. So there's articular cartilage surfacing the bones themselves. These are all structural elements to this synovial joint. Remember, articular cartilage is always hyaline cartilage, always. Now, around this space, or sort of what really creates this space, is something called a synovial membrane. So I'm just going to use a different color for that. And it tends to, it's a double-walled serous membrane. So there's 2 layers to it. I'm exaggerating some of this so that you can see the different tissues better. So we call this the synovial membrane. The reason it gets its name is because the cells in this tissue secrete synovial fluid. Remember, that's the stuff that has hyaluronic acid in it, and the fluid is actually secreted into this space. So this is a fluid-filled space here to help reduce that friction. Outside of the synovial membrane is a fibrous capsule. So I'll just use a different color for that. That's coarse fibrous connective tissue that has collagen fibers in it. That lies on the outside of the synovial membrane. And then exterior to that would be the ligaments, the reinforcing ligaments. And I think I've exhausted my color choices except red, but I'm going to use that for vessels. So on the outside of here, I'm just going to I'll layer this. Remember, this is dense, regular connective tissue. That's what makes up ligaments. The more of these we have, the stronger the joint. And then nerves and vessels actually penetrate all the way to the synovial membrane, to here. So the vessels bring nutrition. I'm going to put all the way to. So those secretory cells in the synovial membrane are supplied with nutrition. Whenever I say nutrition, think of things like oxygen, obviously. And then there are nerves also penetrating this as well. that allow us to, our central nervous system to detect sensation and also send impulses to the muscles around that. So finally, sort of last but not least, the periosteum of these bones would be deep to these ligaments. The ligaments would actually drape on the outside of this bone, and in here would be run out of different colors, and I don't want to confuse you, but actually in here would be the periosteum of the bone. So this is just filled with synovial fluid. So that makes up this synovial joint. These are the most movable joints in the human body. But they range in motion. For example, your pectoral girdle, which is your shoulder joint. Your shoulder joint is the most movable joint in the human body that I'm aware of. But because of that, it's very weak. So all of that, you can swing your arm around 360 degrees, obviously in the lateral plane of your body, just about. So it's incredibly movable, more so than your hip joints, your knee joints. Your elbow and your knees are actually hinge joints. Those are not nearly as freely movable as your shoulder joint, the pectoral girdle, but with movement comes weakness, structural weakness to allow for that movement. So before I end this, what I am gonna end this final bit of the lecture on is movements from your book. So let me grab my textbook and I'm gonna go through each of the types of movements in the joint chapter. And I will ask you some questions on the next lecture exam about these movements. There's nothing magic about these. They just basically, there's a name, and then just know the type of movement that is given at that particular joint, and you should be fine with that. So I'm going to give you specific names and numbers for these. In my textbook, I have an older edition, so I'm not going to give you a page number, but I'm starting on like figure 8.5 in the textbook that mentions these type of movements. So the first one is gliding movements at the wrist. That just means moving in a lateral motion. So you can turn your hand, let's get rid of this whiteboard. You can move your hand at your carpals, at your wrist like this. That's a gliding motion. Angular movements, flexion and extension. They use the head going down and up as flexion and extension. I prefer to tell students, these are typically flexion and extension are at hinge joints. So like at your elbow right here, when you flex, you decrease the angle at this hinge joint. So I'm at 180 degrees right now at my elbow. When I flex my arm, I'm decreasing the angle to 90 and then 45. So that flexion and extension refers to decreasing and increasing the angle, typically at a hinge joint. Hyperextension, you probably know this, means going past the point of normal extension. So rather than 180 degrees here, if I hyperextended my elbow, which I'm not going to do, obviously painful, that would go past 180 degrees. Flexion and extension, I just described those. Rotation versus circumduction. So rotation, the definition of rotation would be turning on an axis, like I'm doing with my finger. Those are also found, I use at the neck joint, I'm rotating my head. So the axis of my cervical vertebrae is vertical. That's not moving, but I can rotate on that axis. That's rotation. Also, I'm going to hold my arm out to you. Rotation, if I hold my arm straight out and I just rotate my arm like this and keep the axis of it in one plane, that's also rotation. Circumduction is very different. Circumduction is described as scribing a cone in space. And that is what we can do with our arms. You can do this with your legs. It's more difficult. Circumduction is doing this. So the movement is here at the pectoral girdle, not just rotating on the axis. So this is rotation. Circumduction, I'm scribing a cone in space with this being the point of the cone, and out here at my hand being the end, the wide circular end of the cone. Abduction and adduction. Abduction, AB, just means moving usually a limb, but moving something, an appendage, toward the midline of the body. Sorry, that's adduction, ADD, is toward the midline of the body. So if my arms are out here, let me move my screen. If I hold my arms straight out and I move them down toward the midline of my body, that is adduction, ADD. Abduction, AB, is the opposite of that. That's starting with our arms at our side and moving away from the midline of the body. Obviously, you can do that with your legs too. Rotation, we already did. I'm on now to the next set of diagrams. Pronation. Pronation just means turning the palms of the hands downward. Okay, supination is the opposite movement. That's turning the palms of the hand upward. Inversion and eversion is something done with the foot. I'm not going to stand up and try to do this for you, but if my foot is sitting flat on the ground like this, inversion is turning the sole of the foot toward the midline of the body, inward. Eversion is turning the sole of the foot outward like this. Elevation and depression. Elevation, just like the word says, means moving something up, as the mandible. Depression would be moving it down. So when we open our mouths, that would be depression. When we close our mouths, that's elevation. We can also elevate our scapula on the backside, our shoulder blades. If I move my shoulders this way, that's elevation. And depression is moving downward this way. Protraction, retraction is what we can do. It's a very specialized joint. This, the mandible, the lower jaw, we can jut our jaws out forward. That's protraction. Retraction is pulling it back in. And finally, opposition. Humans can do this. We have fully opposable thumbs. Opposition is taking your thumb and touching it to your pinky, pulling your thumb across the palm of your hand is opposition. So I did want to go over those angular movements with you. I'm just going to ask you a handful of those, not a lot, maybe not even a handful, just a few questions on those specific body movements at particular joints. So that's it, guys. I'm done for today with the lecture. I'm just going to stop recording and then I'll allow you to answer any questions you want. So let me hit this.